Good morning, good afternoon, good evening. My name is Beate Ringwald. I'm a third-year PhD student with the MRC Doctoral Training Program in the Department of International Public Health at the Liverpool School of Tropical Medicine. My research project is affiliated with the ARISE Hub, and I'm currently based at LVCT Health, Kenya. Today I present lessons from my participatory research project in an informal settlement in Nairobi, Kenya. As displayed here, I'll provide the background and introduction to my study. I'll outline the methods, explain some lessons from the study, and conclude with conclusions. In Kenya, 1 in 3 women and 1 in 5 men experienced intimate partner violence in the last 12 months, while countrywide 7% women and 4% men live with HIV. All rates are higher in informal urban settlements. Research suggests that intimate partner violence and HIV are correlated in multiple complex ways. Integrated intimate partner violence and violence prevention interventions mainly target women. Opportunities for creating linkages between existing HIV and violence prevention programs remain underutilized. Community-based participatory research, CBPR in short, is a tested approach for doing research with instead of about people. CBPR, researchers collaborate with people who are affected by the study topic as co-researchers at every step. Knowledge is produced and used jointly to generate change in the community, as illustrated by the reflection and action cycle. Health policies, including Kenya's framework for integrating HIV and gender-based violence services, frequently propose community participation in research and programming because of ethical benefits and the potential to improve health outcomes. Policy development and implementation, however, are often top-down processes with limited community involvement. Both intimate partner violence and HIV are difficult areas to research as an outsider. It can be difficult for research to lead to lasting social changes. The aim of my presentation is to describe lessons from community involvement in research on intimate partner violence and HIV in an informal settlement in Nairobi, Kenya, using the ALIV principles and steps shown here. I formed and trained a research team that involves, besides myself, 2 Kenyan researchers, as well as 11 community co-researchers from Korogosho, including 4 community volunteers, and 7 community members from marginalized groups like people with disability, gay people, and sex workers. Together, we developed tools, conducted 11 focus groups with 56 women and 32 men, and interviewed 10 key informants, including healthcare workers, youth, and community leaders. As researchers, we guided co-researchers through a participatory data analysis process. The ALIV principles provided an essential underpinning to our study. Because studies in East Africa reported high rates of intimate partner violence against women and men in informal settlements, we included females and males as co-researchers and as participants. To amplify women's voices, we usually asked women and men to do exercises separately in smaller groups before discussing ideas with each other. We learned that women and men lack opportunities in the family and in the community to speak with each other about issues that concern them. Gender mixed focus groups therefore facilitated dialogue and learning. For example, young women and educated young men about HIV pre-exposure prophylaxis. The young men were clueless because they are not targeted by pre-exposure prophylaxis programs. Given the diversity of co-researchers, we set ground rules together. Respectful relationships are the backbone of our study. Co-researchers frequently refer to the research team as a family, by which they mean it is a safe space for everyone. We recruited additional co-researchers when the research team recognized that views of Muslims and women who have sex with women were underrepresented. In addition, co-researchers taught us as outsiders how to involve marginalized groups like women who have sex with women, an otherwise hidden group in the neighborhood. Confidentiality and privacy were critical for everyone, but particularly important for sex workers and gay people because sex work and same-sex relationships are criminalized in Kenya. We discussed confidentiality individually and as a group, helping co-researchers distinguish information that was confidential from information that could be shared outside activities to raise awareness in the community. When we reviewed group norms, co-researchers rated confidentiality as the most important rule. We jointly developed a working definition of intimate partner violence to create a common understanding of the problem. Co-researchers clarified the wider social and economic context that shape intimate partner violence and HIV risk. Group counseling sessions helped us as researchers to process experiences that we made during the study and better understand the challenges and choices that people living in informal settlements face. In research, people in Korogosho are usually targeted only as informants and are rarely informed about the findings of a study. We built a capacity of co-researchers and involved them in decision-making, data collection, and analysis. To facilitate participation, we communicated in Swahili language, with translation for me, and used visual methods. Co-researchers have been enthusiastic and committed throughout the study. Spacing research team meetings made us progress slowly, but it gave co-researchers time to digest new ideas. Participation and capacity building were time intensive. With the constraint of a PhD research project, we faced trade-offs between the level of participation and delivering research outputs. To complete data collection in time, we could not provide the depths of training that co-researchers would have needed to facilitate the main group exercises during focus groups. Hence, they took on smaller roles. Co-researchers' full involvement in data analysis, adapting the 6 steps of the DEPICT model, required more time than anticipated, but enhanced the quality and ownership of findings. We put measures in place to mitigate the risk, including COVID-19, infections, unintended disclosure of HIV status, and re-traumatization. After focus group, co-researchers collected feedback from participants. None of them reported adverse events during or after focus groups. We learned that ethics and safeguarding were not one-off activities for the protocol, but required regular attention to recognize and mitigate potential risk. Co-researchers helped identify suitable solutions. Contingency plans enabled us to respond quickly to emerging issues and to remain focused on the study. Throughout the study, we held group reflections as researchers and with co-researchers. We reflected on differences between social power of individuals, assessed functioning of the research team, and the progress of the study, documented lessons, and adjusted the study when needed. While ALIV provided us with a framework, we had to translate the principles and steps into methods and actions that facilitated mutual learning and continuous improvement of the research process. This required openness to learn and unlearn from researchers and co-researchers. Community-based participatory research facilitated meaningful involvement and mutual learning among researchers and co-researchers. ALIV has proven to be a robust framework as it guided us in creating safe spaces for women and men to discuss sexual and reproductive health issues. CBPR has the potential for identifying interventions that meet the needs of marginalized people when involved as co-researchers. Researchers may consider CBPR when exploring sensitive topics or stigmatized conditions, when assessing acceptability of novel treatments or interventions, and when developing or adapting programs. I would like to thank everyone who has supported me on this journey, and I thank you for listening.